the pathophysiology, it is very interesting. So, genetic abnormality which we have seen is sodium channel 5A and other sodium channels also, or connexin 43 which is a close interacting protein with the sodium channel, or ITO potassium channel or L-type calcium channel abnormality. There are two different hypotheses. One is a depolarization abnormality, one is a repolarization abnormality. So, obviously when there is a sodium channel loss of function, there is a depolarization abnormality. When there is a repolarization abnormality is because of gain of function of potassium channel, ITO channel. So, there are two different hypotheses which can explain very well the ECG changes. So, this is the genetic abnormality. It can be polygenic also, and there are multiple environmental factors also which can accumulate. For example, fever, rise in ambient temperature and the Brugada provoking risk factors. So, it results in functional abnormality of the ion channels, INA channel, voltage gated sodium channel, calcium channel and the ITO. This is the channelopathy, functional abnormality. So, this results in difference in the expression. So, this is only focal, this is patchy. So, there is difference in the expression of the, here this is the repolarization hypothesis which focuses mainly on the potassium channel hypothesis. So, there is difference in the expression of the ITO channel between the epicardial and the endocardial layer of the RVOT. So, this is this way, horizontal way, between the epicardium and the endocardium. Why is this seen? Because mostly it is epicardial VT or VFib and it is amenable to epicardial VT ablation. So, this hypothesis holds good if we are able to, we want to explain the epicardial, that is the complex substrate of the VT in the epicardial surface. So, this is the voltage gradient during the repolarization because of the difference in the presence of ITO calcium channels in the epicardial versus the endocardial layer. While the sodium channel can explain the RV outflow tract, other QRS fragmentation, ST segment elevation, delay in the action potential, all can be explained by the depolarization hypothesis. So, what happens because of the difference in the voltage, there is a gradient between two different areas of RVOT, there are structural changes which are microscopically seen like any other myocarditis. So, focal infiltration of the lymphocytes or presence of fibrosis or scar which may or may not be seen. It is structurally normal heart. So, these microscopic features can be seen, for example, inflammation, fibrosis, myocyte vacuolization or lymphocytic infiltrate. Macroscopically, we may be able to identify with MRI if we are able to screen more patients with type 1 or even 2 and 3 pattern of ECG, which we are not usually getting to screen. So, if there is a RVOT wall motion abnormality and dilated RV outflow tract similar to that seen in arrhythmogenic RV cardiomyopathy. So, resulting in the structural abnormality which is very rarely seen in the Brugada syndrome because it is the arrhythmogenic disorder with a structurally normal heart. So, this can result in repolarization, and this is potassium, and depolarization abnormality, this is sodium. And there is a baseline abnormality, but the second hit is either fever or drugs or even electrolyte disturbance like hypokalemia, hypomagnesemia can trigger VT or VFib like any other normal patient. So, already there is a baseline substrate and these electrolyte abnormalities can potentiate a polymorphic VT or a VFib. So, this can present with a serious arrhythmogenic event, syncope or cardiac death or arrest. So, as we can see, there is a conduction block here in the RV outflow tract. This is the normal RV, which is early depolarization, normally functioning sodium channel. While here there is a patchy dysfunction of the sodium channel while the RVOT is coming delayed. If you can overlap this and see, there is a normal RV, that is pre-RVOT action potential, while the post-RVOT is delayed and also the action potential is shortened because of the early inactivation of the sodium channel or late activation of the sodium channel. So, it is action potential is narrowed. It is like a short QT, but only in some areas, while the rest of the areas are they are maintaining their normal action potential duration. So, this pattern presents as initial depolarization followed by repolarization followed by the later. This is the RVOT depolarization which is coming later, followed by the either repolarization change or without repolarization change. So, this difference or gradient between the RV and the RVOT is the arrhythmogenic substrate. Difference in the effective refractory period can provoke a re-entry circuit resulting in VT or VFib.